Morning, everyone. I'm Dr. Ravi from Apollo Cancer Center, Bangalore. And my today's paper is Radioisotope-guided lymphadenectomy for pelvic lymph node staging in patients with intermediate and high-risk prostate cancer, the prospective Sentinel study. Well, during radical prostatectomy, extended pelvic lymph node dissection has long been a gold standard for nodal staging and as well providing prognostic insights for further management plan. However, it does harbor few issues like node present outside the template may be missed, and depending on the extent of the lymph node dissection, the perioperative morbidity would also vary. And there have been two recent randomized controlled trials which have been published in European Urology in 2021, which has failed to show any oncological benefit of extended PLND over a limited PLND. So with these issues in the backset, and with a systematic review data showing that a sentinel lymph node biopsy in prostate cancer is almost equivalent to extended PLND has brought in new discussion in the forum. So with these issues in the backset, the Sentinel group set out to further the evidence for sentinel lymph node biopsy in prostate cancer. So they performed a single arm, open label, multi-center, 3 centers to be precise, and a non-randomized study which was performed between February 2012 and May 2019. Around 178 patients were assessed, but then finally 162 patients were included for the analysis. The inclusion criteria is anyone more than 18 years with a histologically confirmed prostate cancer, which is clinically localized, intermediate or high risk. The exclusion criteria were a nodal positive disease or a metastatic disease, any previous treatment for prostate cancer, any previous radiotherapy or surgery in the pelvic region, or any contraindication for general anesthesia. Coming to methodology, they have followed all these steps which was set out in a consensus panel meeting published in BJU International in 2017. And that includes 1 day before surgery, a truss-guided injection of radiotracer, that is 99M technetium nanocolloid, was injected into peripheral zone of prostate, extending from apex till base to ensure a homogeneous distribution using a 22 gauge needle. A total activity of at least 222 megabecquerel up to 300 was given in a total volume of 0.6 ml. Subsequently, 2 hours later, a lymphoscintigraphy was performed, followed by a SPECT CT scan. All the images were reviewed by in-house nuclear medicine physician and subsequently by a central reviewer. Following that, all the approach in this study has been open. There is no minimally invasive approach in this study. So first, the sentinel lymph nodes were searched inside and outside the usual external pelvic lymph node dissection template using the lymphoscintigraphy findings and then a use of intraoperative handheld gamma probe. And if at all any sentinel lymph node was identified in a region, let's say an external iliac region, then all the lymph nodes in that region were removed. Once the sentinel lymph node resection has been done, all the patients underwent extended pelvic lymph node dissection as well. And the number of nodes removed, both sentinel and non-sentinel, the number of metastatic nodes and the locations were recorded. Any perioperative complications were recorded using Clavien-Dindo grading. Coming to statistical analysis, descriptive statistics were carried out and categorical variables were reported as frequencies and percentages, continuous variables and medians or means as appropriate. And subsequently, the diagnostic accuracy of SLNB was assessed by calculating sensitivity, specificity, positive predictive value and negative predictive value. And all of this was performed in R software version 4.1.3. Well, the median age in the study group was 65 years with a BMI of 26. Nearly 3/4 of patients belonged to clinical less than T2A stage, and nearly 60% of patients in this study had a PSA of less than 10. They had a biopsy ISUP grade group of 2, and nearly 65% belonged to intermediate D-amico risk classification. For subsequent to prostatectomy, around 42% of patients had grade 2 ISUP grade group, and majority were T2C grouping. Coming to the results, based on the preoperative lymphoscintigraphy, in 153 patients, sentinel lymph nodes were detected. That is close to 94.4%, totaling 890 sentinel lymph nodes. And with an intraoperative gamma-guided detection of in 142 patients, totaling 788 lymph nodes were done. As you can see in the diagram here, the distribution, the majority of the lymph nodes were in obturator fossa, followed by internal iliac fossa, and then external iliac. The mean number of sentinel lymph nodes which were removed was 4.9 per patient. And sentinel plus extended pelvic lymph node dissection, the median number was 14. And the median operative time for sentinel lymph node plus extended PLND was 70 minutes. Coming to the pathological evaluation, out of 162 patients, 22 patients only had a lymph node metastasis, that is 13.6%. And the lymph node metastasis were limited only to sentinel lymph nodes in 17 of those patients, that is nearly 77.3%. And 141 out of 142 patients were correctly staged by sentinel lymph node, and there was only one false negative patient in this category. And interestingly, they also identified one patient who had a lymph node outside the template of EPLND, which was picked just because of sentinel lymph node methodology. Well, the sensitivity, specificity, negative predictive and positive predictive value of this method to detect patients with at least one lymph node mets ranged from 95 even up to 100%. And at 1 year of follow-up in the overall cohort, biochemical recurrence was occurred only in 23 of these cases. Coming to discussion part, the study group set out with a question saying, does EPLND truly represent a gold standard in lymph node staging, which is with its inherent lacunae like missing node outside the template, risk of perioperative morbidity, and does EPLND have any therapeutic benefit at all, with the two RCTs showing that there's no real oncological benefit with those steps in methodology. And with a sensitivity of close to 0.954, does sentinel lymph node biopsy set a challenge for the established EPLND was the question. And this sensitivity is much higher than any other preoperative staging methods, including PSMA PET-CT. And apart from that, there has been a recent meta-analysis where it has confirmed that every 1 in 20 patients undergoing EPLND, a metastatic lymph node would have been missed without a sentinel study. So with all these information at the back set, with a sensitivity of close to 0.94 and with accuracy of 99%, the study group set out to challenge the conventional dogma that EPLND is the gold standard of lymph node staging in prostate cancer. However, it does have some limitations. There was no analysis of long-term oncologic outcomes in the study group. There is no comment on sentinel lymph node biopsy specific intraoperative morbidity because all the patients anyway subsequently underwent a EPLND. It was only open approach between 2012 and 2019. And as we all know, the current practice, the minimally invasive has taken over the landscape with a very bare minimum open approach being done, and if it really makes any difference at all. And majority of the patients in this study group belong to intermediate risk, and very few node positive patients would have been included. And the sentinel lymph node was picked up only in 87.7% of cases. And what about rest of the cases? And an unavailability of a dedicated gamma probe for MIS when they did the study. Coming to the strength of this study, it was a prospective, multi-center design. It followed all the established expert consensus statement, which was published in BJUI in 2017. And now, currently, we do have a radio-guided robotic surgery can be done using drop-in gamma probes. So we really don't know if it does make any difference in the management. Coming to the conclusion, this prospective study does show that SLNB is an effective method for lymph node staging and has a potential to avoid significant number of ELNDs in patients with intermediate or high-risk localized prostate cancer. The place of the sentinel lymph node for staging needs to be defined in future studies with a much better large volume and with a much longer follow-up, as it could be used alone or as a part of strategy that includes PET-CT in high-risk prostate cancer has to be seen. Well, coming to Indian scenario, as we saw in the patient characteristics and tumor characteristics, our patients behave much, much different from the Western set of population, and our incidence of node-positive diseases are much higher. So does this approach really have a benefit in our subpopulation needs to be looked upon. Thank you.